Hello, welcome to the webinar series hosted by Happiest Health. Happiest Health is a global knowledge enterprise focusing on health and wellness. We bring a series of webinars on various health topics. I'm Revati, and I will be the moderator for this session. Parkinson's disease, or PD, is a neurodegenerative condition where the brain does not produce enough of the hormone dopamine because the cells that produce it are not alive. As dopamine also regulates motor functions, this results in movement disabilities. According to World Health Organization, PD is the fastest growing neurological health condition. Although it is known as an old age disease, there are cases of early onset. The typical symptoms include tremors, slow movement, freezing of gait, apart from anxiety and depression. The exact cause of PD is not known yet, and currently there is no cure for this condition. However, understanding the condition and adequate support will improve the quality of life of those living with Parkinson's. On account of World Parkinson's Disease Day, we bring to you this webinar session that will discuss breaking the stigma around Parkinson's. Joining us are Dr. Pramod Pal. He's a professor of neurology, a movement disorder specialist, and the program director of postdoctoral fellowship in movement disorders at National Institute of Mental Health and Neurosciences. He is the founding secretary of the Movement Disorder Society of India. He is the president of the Parkinson's Disease Society of Karnataka, co-chair of the Education Committee of International Parkinson and Movement Disorder Society, and Professor Pal has more than 415 publications in various national and international journals and books to his credit. He is also editor-in-chief of the journal Annals of Movement Disorders. His areas of specialization include movement disorders, especially Parkinson's disease, dystonia, ataxias, and human motor physiology. In addition to this, his area of expertise include transcranial magnetic stimulation, genetics, and neuroimaging in movement disorders. Welcome to the panel, Dr. Pal. Next up on the panel, we have Dr. Prashant LK. Dr. Prashant is the founding member of the Movement Disorders Society of India and is currently the treasurer of the society. Dr. Prashant is also an active member of the International Parkinson and Movement Disorders Society. He is also the principal investigator for the Pan-India study on the genetics of young onset Parkinson's disease. He currently runs the Parkinson's Disease and Movement Disorders Clinic in Bengaluru, and his areas of interest and expertise include understanding the genetics of movement disorders, continuous dopaminergic stimulation therapies, deep brain stimulation, and Wilson's disease, among other areas. Welcome to the panel, Dr. Prashant.
Hi.
Next up on the panel, we have Dr. Pratima Katyala. She is a dermatologist practicing in Tirupati, Andhra Pradesh, and she's also the author of the book Insignificant Me. After graduating from Andhra Medical College, she moved to the UK for general medical training, followed by dermatology specialization, and then relocated to India. She was diagnosed with young onset Parkinson's disease at the age of 38, that's 6 years ago, and is on medication for her condition. She dances and practices yoga regularly to keep herself fit. Welcome to the panel, Dr. Pratima.
Hello, everyone.
So we have a panel of experts here, and one of them who's living with Parkinson's disease. So I'll start with you, Dr. Pratima. When did you first notice the symptoms of Parkinson's? Did your profession help you in early diagnosis?
Well, I think yes, definitely being a doctor has helped me in an early diagnosis. The first thing I noticed was probably when I came to India, I started going to this cosmetic dermatology sessions, and I was not able to focus the laser. You know, the small lesions on the face, and you had to focus the laser pen on them. And everybody was able to do it except me. I didn't understand what's going on. So you just keep ignoring that for a while, and then later on, it's becoming more prominent. It's like, it's just me who is not able to do it, and everybody else is able to do it. And when I talked with my husband, he just examined me. I clearly remember the day we were traveling in a car. He examined me in a car, and he said, "There's some rigidity in your hand on your right side." I was like, "Is it?" And he did it again, twice. And he said again, "Yeah, there is rigidity." So I kind of tried to, I teach MRCP, you know, general medical training, and PD is a classical exam case. So I tried to connect all these things. Why am I not able? Is it a fine tremor? And the rigidity, can this be PD? But I'm too young, and I'm a female as well. So you keep postponing, you keep it aside, you stop thinking about it, you try to avoid thinking about it. But it's there in the back of mind. I know it's PD, but it has to be confirmed by a neurologist. But it took me at least a year to go and see a neurologist, who then actually said, yes, it looks like PD.
That's still sooner than somebody who may have not been in this profession, I'm assuming. Was there any stigma that you faced once you were diagnosed?
Well, rather than the stigma, it's more like a self-stigma, right? You know, you don't accept the disease, you don't believe it, you're too young. Like I said, I was 38 around that time, and I was a female. As far as, you know, it's more common in males, and it's a disease of old age and all those things. So you don't believe. And my signs were very subtle. Maybe it's not. You kind of don't accept that the self-stigma first. You don't accept it at all, because initially it's very subtle. And you think maybe it's not, maybe it's just all in my head, maybe I'm overthinking. All these things come into play. I don't know about the general population, what they think about it, but acceptance takes a while. It takes a while for you to accept that you actually have a disease. Probably that's the first stigma that you go through.
Right.
But there are various stigmas you go through as the disease progresses. It changes all the time.
Right.
It's just not the same every day or every time. Yeah.
Right. Right, Dr. Pratima, we will get into more details on self-stigmatization and how you really overcame that. But before that, Dr. Pal, from an expert's point of view, how do you break the news to the person when a diagnosis is made? And what advice would you give to the person and their caregiver?
So this is a common thing for us, but being in a tertiary care institute, but wherever you are as a movement disorder specialist, the patients come after over 1 to 1.5 years. Usually we do not get in the very, very early stage. And by that time, already the patient may have known that they has Parkinson's disease. So the first thing what I do, and is a very good clinical history, good here details of for the patient, caregiver. And by this time, within the next 10 to 15 minutes, we get a rapport with the patient and we take them into confidence. Then we discuss about Parkinsonism. What is, just like give an example of a fever. This is a fever, this is like a Parkinsonism. Parkinsonism just has only symptoms of stiffness, slowness, shaking, etc. But there are different causes of Parkinsonism, and I try to explain that. And then I take him or her through the journey, what are the causes of Parkinsonism, and try to show that Parkinsonism, what the patient is having, is a Parkinson's disease, which is much, much better than any form of Parkinsonism, which is prevalent now, because it is not a fatal disease, and it is, you need not panic. And you are fortunate that among all the types of Parkinsonism, you have PD, Parkinson's disease, which is very well responsive to treatment. Like it is like any type of disease, like, blood pressure, diabetes. It is just a lifelong treatment you need. And over time, the doctors will change the medications, and you have to go through some of the new symptoms. So I highlight over the time horizon, it has not started. The patients get a relief that it is not started today. It probably has started about 10, 15 years back. It is not, and it is not a patient's karma or something patient has done. The patient wants to know that whether anything he has done has caused this thing, which is a great assurance to them. Look, you have not done anything to cause this Parkinson's disease. Only in 10-15% of the patients you get a genetic cause. So they get the assurance that, okay, we have got a disease, we have not done anything, it is just a fate. And then I take them through what may happen in the next few years. And also I deal with the non-motor symptoms. Okay, so you can have depression, anxiety, constipation, etc. And by that time, the disease, what I confide in the patients, caregivers, they get quite receptive to the diagnosis, and they get assurance that, okay, this disease is treatable, nothing much to worry about that. Now, we emphasize that there is no cure. Like any other disease, there is no, hardly any disease are there which is a cure actually. Now, what are the advice I give to the patient after breaking the news, after taking into confidence, we go through the records, etc. Then I give a standard advice to all the patients and caregivers of Parkinson's disease that look, that all the Parkinson's disease, all the patients with Parkinson's disease are not the same. You all are, different, the varying combinations and varying response of this treatment to the medication. So you should not compare with another patients of Parkinson's disease. Okay, don't seek multiple consultations from doctors, and there will be ups and downs in your life in day-to-day circumstances, and these will be there. It will be treatable. There is no issues. I highlight them about the non-motor symptoms. And then I explain in details about what type of options are available. It will be for the early Parkinson's, obviously it will be the medications. What are the medications available? What are the cost? What is the profile, side effect profile? And I ensured them that it is only one medicine is needed, not more than one, more than two, etc. And then we will manage accordingly. So by this time, in the next 10-15 minutes, the patient gets the confidence. And I advise them that the caregiver burden, I tell them about the caregiver burden, the depression, what are the patients, the caregiver of the patients can go through. And that is very important. Treatment of the caregivers, the old spouses, that is also very important, and that should be taken care of. So this is in a nutshell what I tell the patient and the caregivers. I obviously tell everything about the drugs and later on surgery, etc., but not in the first visit about the surgery, etc.
Right. To sum it up, give a realistic picture of what to expect.
There is a realistic expectation. We are starting the medicine. There is another thing which I forgot to tell you, that all the medicines has to be started very slowly and gradually build it up. There is no fast track. So a very slowly over 1 month, 1.5 months, there will be increase. You may have to cut down the medicines because there can be nausea, vomiting, side effects. We judge the patient by different symptom category, whether this patient needs levodopa or a dopamine agonist, etc. And then tell them there's a realistic expectation. Everything will not go away. Some parts will remain with you.
Right. Thanks, Dr. Pramod. Dr. Prashant, what are some of the misconceptions about Parkinson's disease, and what are the hesitations about consulting a neurologist that you've observed in your practice?
I think the biggest misconception among people is that they come with a name that I have Parkinson's disease, and they are shattered for their life. Many times when they come to us, they are so shattered, feeling that their life is finished. They have found some disease which is not there in their vicinity. No one is affected. And they would have done some Google search and they would have seen only the end stages of the Parkinson's disease, feeling that nothing can be done now. And this is the biggest myth what people come to us. And this is one thing where people should believe that Parkinson's disease is a treatable disorder. People will lead a near normal quality of life and does have significant improvement in whatever works they're involved in. Either it can be professionalism or it can be the social life or family life. That is what is one of the biggest myth what I've seen when people come to us.
Okay.
I think more than that, subsequently, that people have various set of myths coming to them, or they come with us different set of issues coming to us. They feel that, okay, why did I develop schizophrenia? This is where my life is finished, my things are changing on, which is not the whole truth. That's what we are looking forward for. There are various ways how people look into it and how people develop this set of symptoms.
Right.
I think that's where I think the biggest myth is. That's the biggest myth what I hear from most of the people when they come to us. Thank you.
Right. Thank you for clearing that misconception, Dr. Prashant. While there may be no cure yet, it is definitely a manageable condition. That is something that people who have been diagnosed should remember. Dr. Pratima, coming to you, you did talk about self-inflicted stigma, and that's very, very important as once the diagnosis has happened, or even before that, once you start noticing those initial signs and symptoms. How did you overcome that self-inflicted stigma?
It's a gradual process, so it takes a while. So the first thing is accepting the diagnosis. Like Dr. Prashant said, we see patients who are end stage. We don't generally tend to see, they don't come out. The young patients generally don't tend to, you don't see that many. They are not a major population. You don't tend to see that many young patients with Parkinson's, and they don't usually show it off. I try to hide. Every one of us try to hide, initially, at least for the first few years. So hiding is important. I don't know if you ask me, how did I overcome? Means family. Family helps. You talk to your family, having a doctor's friend, so many doctors as your friends and in the family as well. So that helps. You kind of have a bit of confidence that it's going to be okay. You've seen some patients and they tend to counsel you. They tend to give you some support and all those things. So, and being a woman itself, it's kind of an advantage, I think, being a man, because the financial constraint is not there on you. So half the burden, most of the time, most men in young onset Parkinson's disease what is their main issue is, how am I going to look after my family? I'm the breadwinner. Now, for being a female, for me, that part is taken out. So I don't have that much pressure on me that I had to make an earning, I had to make a steady financial development or progress in my career or anything like that. So that kind of eased off a little bit. You had to talk with the men, though, how they overcome this. It's kind of different with me. So that pressure is off, but I still want my financial independence. So you make some changes. You do change accordingly. You know that you're not capable like before, so you need to make some changes. Initially, it was a lot of anger. I don't know how I overcome that anger. It took me quite a while to overcome that. And then later on, I made some changes. Now I see only medical dermatology. I employed somebody who can write the prescriptions. For me, even though I take medications, when you're on a long clinic, you do get these off times when you can't write. I can't write prescriptions sometimes. So I employed somebody who can write prescriptions for me. So you need to change. Cosmetic is not my specialty now. I'm more into medical dermatology. So you need to make some changes to your career. You need to make some changes to your family itself, and prioritize your workload. Prioritize your workload. But the best thing which helps me, I should say, is the exercise and the meditation. Yeah, those two actually helped me initially. Exercise, you get these endorphins and you feel so good. And meditation, it tends to take out that anger bit of your disease. And it helps overcoming a bit of stigma. Now you reach at a stage of acceptance. Whatever happens, let it happen, let it go.
Dr. Pratima, I'll come back to you in detail about the dance and yoga and meditation and how it helps you. We'd like to hear more about that. But just quickly summing up what you said, one is accepting the diagnosis and the consequences of that, or the challenges that come with it. And secondly, accommodating those challenges and making changes in your life to accommodate those. And one important aspect that you talked about is the role of the caregiver, the family. Dr. Pramod, I'd like to come to you for that. What are the telltale signs of self-inflicted stigma that others can recognize, the caregiver can recognize, in case it goes unrecognized by the person themselves?
Yeah, already Dr. Pratima was highlighting about the stigma. So stigma is nothing but an attribute that you are wrong, you have discredited, okay? And it is basically for no fault of yours. So if you see the Parkinson's disease, there are two categories of symptoms. One is motor symptoms, and that is the most important thing, is the shaking of the hand, tripping while walking, difficulty in getting up. So by these type of signs, the public, so basically what happens, self-inflicted stigma is that they go from a public to a private world, okay, to avoid people seeing them, that she's having a shaking of the hand, having after the medicines, they start having jumping, they think that something funny is happening to that person, doing it purposely, or imbalance while walking. So there's the motor symptoms, or shaking of the hand, cannot serve a food. So eating with a spoon, there's a disaster. So these are the things. And then in the workplace, basically we are talking about the workplace, or even the home is a workplace. There's suddenly medicines cause a lot of sleepiness, suddenly you doze off. You have depression, anxieties, that is one of the most important thing in the initial stages. So non-motor symptoms and motor symptoms compel the patient, the initial part of the journey, to isolate themselves. So you said, what are the telltale signs? Say they try to seclude themselves, they try to come away from the society, okay? And they try to have their own cocoon. So they are more, the determinants of self-stigma is more when you meet somebody who has not a Parkinson's disease, who you meet somebody in an unfamiliar place. So they are much better in their own surroundings. So the most important thing, what they try to do, this is a general perception, that most they try to do is that try to come out from the social gatherings, and they have depression. They do not want to interact with anything which can bring out their symptoms, like if the right hand is shaking, writing, or playing, if the voice is shaking, playing a high note, singing, what they were doing earlier, music, dance, etc. They all try to stop them. The hobbies they stop, the social gathering they stop. Even if they were supposed they used to go and eat together, they stop eating together. because to avoid that, the people will see and what they'll think. Probably this is something that she or he is doing purposely or because of the disease. So basically, it is a withdrawal or yourself from the society in the initial stages. But as you said, that when the acceptance stage comes, you have to earn money, you have to do everything. Gradually, they come out in the society.
Right. Thanks, Dr. Pal. Dr. Prashant, is the stigmatization escalated due to a late diagnosis? In Dr. Pratima's case, it's an early onset, but if there's a late diagnosis, is the stigmatization or the stigma escalated?
I don't know. The point is, stigma is not related to the symptoms. I think stigma is related to the diagnosis. There are many people whom you can see, they'll be having tremors since their early childhood, mid-childhood, or adolescence onwards. And they know that in their family, tremors are there, they're least worried about it. By giving a name, people get stigmatized. That is where the biggest issue comes out. And the most important stigma what is associated is here with the name of Parkinson disease, which is unlike HIV, unlike some any other medical disorders currently at this point of time, has a significant treatment options. It's just the awareness what the disease is involved, why it is in, why it happens. That is what needs to be, awareness has to be increased. People, even though like what happened with the doctor, even though she acknowledged it was there, she was trying to postpone to avoid to get that name. That is what I could feel, that even though there was an inner sense of thought process was there, yes, I'm having Parkinson's disease, but trying to avoid it, to avoid the name. I think the goal is to create more awareness is required. Once we create more awareness about Parkinson's disease, why it is nothing to get worried about, why early diagnosis, good treatment does improve their quality of life, and people can lead a better quality of life if you can compare to other degenerative disorders. Probably among all the degenerative disorders, Parkinson's disease is one degenerative disorder which has tremendous therapeutic aspects, which improves the quality of life. I think our effort should be is to increase this awareness to reduce the associated stigma of getting the name of Parkinson's disease.
Right, Dr. Prashant, very clearly put out. It is about increasing awareness and also the fact that the stigma is around naming or giving a term or name to those symptoms. That is where the stigma comes. And we hope to create more awareness with sessions like these. Dr. Pratima, Dr. Pal briefly touched upon the workplace stigma. And I'd like to come to you on this question. Dr. Pratima, you are a practicing doctor. And although Parkinson's, like I mentioned in the intro, is known as an old age disease, you've had an early onset. Does that make a difference in the way society stigmatizes? Because I remember you telling me that if your hands shake as a doctor, you're seen as an incapable doctor, a nervous doctor. How did that pan out for you?
That's always there, because when somebody sees a doctor with a shaking hand, especially when you're young and if you don't have like silver hair, people tend to think, she's too young, she's not experienced, and on top of it, she is nervous. Actually saying that, because I'm constantly compared with my father-in-law, he's a dermatologist as well. So that's what I see the difference between the patients at the workplace, because being a female is an issue, being a little bit younger is an issue, and coming with a shaky hands is also an issue. Patients do point that out, but I had to overcome this. Sometimes it just shows up, there's no way I can hide it. Sometimes my medications help, it just goes on. And I'm at a stage where, like, if they see let it be, they're going to look at my face, not at my hands. So, and even if it is let it be, whatever they can, I can't change everybody's. I'm not going to go along teaching everybody what I have, right? I'm there as a doctor, so I need to, my words and the way I counsel them about the disease is more important than them looking at my hands. So in a way, yeah.
Quickly ask an additional question to that, Dr. Pratima. Do you have had to, did you have to explain this again and again to your patients about the condition, tell them why your hands are shaking, and at least initially?
No, I usually talk, patients don't understand. Once you start explaining about PD, because they themselves know nothing. And half the time I'll end up counseling them about PD, wasting their money, who have come here to have their disease solved, and on top of it, I'm talking about my disease. So I don't think it's probably ideal to talk about PD in a clinic. The team, initially when I was doing teaching as well for the MRCP exams at Hyderabad. So for the team, I had to let them know. It has taken some time again. All of them are doctors, they're going to notice at one stage or the other. When I told the team about my PD, they were actually quite accepting, would you say. They made some workplace adjustments for me. They gave me the cases where I am more capable of. They made online teachings available for me. So it's kind of people, your workplace are generally more accommodating than you normally think. It's me who was actually having all this fear and anxiety, but the workplace people and the team were actually excellent. They were all very quite accommodating and very nice to me. That was how it went. First coming out with it, yeah, is probably the best way. There's no point in telling the patients you're going to end up counseling them about your disease all the time rather than talking about their disease. So it's double the time.
Right.
Yeah.
Right. Dr. Pramod, I'll take that question of workplace accommodation from an expert's point of view. As a doctor, you said you would counsel while you break that news to the person with Parkinson's or their caregiver. Now, how can workplaces accommodate people with Parkinson's with regard to their physical symptoms? People with PD also face anxiety, depression, and hallucinations. So how can the institution or co-workers help them?
So, workplace is a very vague thing because, you may be fortunate, the patient may be fortunate if the workplace is in a medical surroundings. Okay. But we do not know what is the workplace. Okay. But it is a place where person is going from 9 to 4, probably doing a job, sometimes in the night shifts and earning money. Okay. And they have probably some type of, insurance, etc. So basically what we need is workplace hygiene for Parkinson's disease. Okay. It should be a personalized support for people with PD to reduce the stigma. Now, once I said this, how can it be achieved? And I'll tell you what to be achieved. So achieving the workplace, hygiene is education. Counts education of the employer, education of the people who are working there along with the patient. So education of the staff, those are very important. Just basic education about what the patient of Parkinson's disease problems, what are the problems of the patient with Parkinson's disease, the motor problems and the non-motor problems. Okay. So they should be sympathetic, but not that they are going to just go on sympathizing, but basically it should be that patient should be aware that the person, the Parkinson's disease patient who is sitting there or working has a limited ability, at least in the mid stage or the later stages. They have medicine related side effects, they have disease related problems, they intermittently need to take the medicines, they need sometimes, naps or support, etc. So, but to make a workplace which is mobility friendly and, less chance of falls, etc., I think there should be less crowded corridors and there should be sometimes, most of the patients in the mid stages, many patients will have a freezing. So they have a difficulty in, walking in a narrow corridor. So there should be well lit, there should be stripes in the corridor, handrails should be there, the toilet should be there with the handrails. And these are the things which can make the life easy. Okay. And then if the employer or the all the colleagues are accommodative, okay, they can give some place for short relaxation, naps. Even in a normal person, not only PD, it is recommended that every 2 hours you should have a 20 minutes relaxation. So these are the things which should be given, especially in these patients. And it should be understood that these patients need to take medicines every 4 to 6 hours. And after taking the medicines, they can have other problems like dyskinesias. So these should be, taken care of in a different way, and so that the patient doesn't get, very stigmatized and offended. But at the same time, the colleagues are helping them. Okay. And there should be also provision, if possible, if the patient is a permanent employee, etc., working from home. I know one of my first patients was a computer, working in one of the big computer firms. Then he is working from home for a long, long time. So working from home is definitely a soluble solution. And then they should also discuss about, look, what is the employment benefit, insurance, all these things need to be, chalked out. because many patients, because if you go to the literature or the statistics, there's a lot of discontinuity of the job. The patients are just told to go back because they cannot contribute effectively, and employment, sacking from the employment, etc., is quite rampant. So job security there should be there. So these are the patients with the motor problems. Now, and you are telling something about the non-motor problems also, isn't it?
Yes, those with anxiety, depression,
Anxiety,
hallucinations.
depression is a part and parcel of patients of Parkinson's, but this is, already it has been covered. But again, I'm telling that the medications and all will be decided by the doctor. But in the workplace, you need to have a compassionate, colleagues as well as the employer, and can have a patient hearing if the patient wants to talk. And sometimes there should be emotional fatigue, etc. And other things, the employer or the things should know that there could be some types of psychiatric problems in these patients after in the mid stage, or because related to the medications. They can have sometimes of a pure belief, false belief that somebody is trying to blame him or her. So they are called delusions. So they should be aware and do not give too much of importance to these things. Okay. So these should, and sometimes the drug induced, sometimes excessive too much daytime sleepiness, etc., happens. And they should be very careful about that, not to just blame the patient that you are dozing off, etc. They should be compassionate and they should know what they're dealing with.
Right. So not just sympathizing with them, but going beyond that, understanding the symptoms, recognizing the signs and symptoms, as well as accommodating those in the workplace to ensure that their productivity is also not really affected. Thanks, Dr. Pal. Dr. Prashant, for someone facing a recent diagnosis, what message would you like to convey for them to overcome self-stigmatization, including at the workplace, and any social stigma that they may have? And this, I'm talking from an individual perspective. We talked about what workplaces can do, what caregivers can do, what can an individual do?
Look, many times when new onset Parkinson disease patient come to us, it's more about talking to them, taking the fear about Parkinson disease away from them.
Okay.
Primarily at that point of time, they don't require therapies, means medications, what we regularly use for Parkinson's disease. They'll be having subtle features, minimal features, and these minimal features, they are worried about it, than it causing the symptoms. Most of the time I sit and talk to them, telling about what is aging-related disorders, how things happen, why certain people will develop certain type of aging-related disorders earlier than other set of people. For example, I usually take an example of graying of hair for people when I start comparing to talking to them. Some people develop graying of hair around 18 years or 20 years. Some people develop around 40 years. Some people have good black hair still in their 60s also. So it based upon their genes. Doesn't mean that once you develop a graying of hair, your life is finished. Yes, at around 18 to 20 years of age, when you develop it, you're much more anxious about that. Like, will I get a girlfriend? Will I get married or not? What will happen to my boyfriend? So those type of concepts, it's much more of a fear associated with that. It's not a problem. It's a fear associated with them. And Parkinson's disease is like that. You develop a symptom, everyone can notice what you have developed. It doesn't mean that people have noticed it, doesn't mean that you have been hindered in your work or you're not able to work at all. So that is the most important lesson what they need to understand. Not only that, this is a disorder where treatment options are available. You want, we can give treatment today. Like you want to color your hair, you can color the hair today itself. If you don't want to color, it's okay. It's your personal choice. It's not like something you don't do it and you are going to lose anything. No one is going to come back and complain to you telling that, look, you should have started treatment 2 years back or 5 years back. Why didn't you start that? Now, because you're not taken treatment for last 2 years or 3 years, this is why you are ending up with this type of issues. Probably this is what you'll hear with patients who are having long-standing diabetes, hypertension, where we call that because your diabetes was not under control, your hypertension was not under control. That is why you have developed this complication. This type of statements you're not going to get with Parkinson's disease. With Parkinson's disease, we are there to treat you as and when you want, and you have good treatment options. Among all the options of treatable disorders or degenerative disorders, when you look into it, this is one thing what you can have it and get it treated without getting worried about. Many times, this type of counseling helps them to reassure themselves. And so many times I've seen people, okay, that is good enough. I don't have to take treatment now. I'll come back after a month or two. Then I'll take a call whether if I need to start on treatment. Most important, what I do is encourage them to increase their social life and what you call it as mental activities. Many people work in their life without doing anything as such. increase their social activities, be happy, increase your physical activities. This automatically increases your dopamine levels, and that helps to suppress the symptoms sufficiently without taking treatment for a certain more amount of time also.
Right. Right, Dr. Prashant. And in the last round of questions, I'll go go on to discuss beyond L-DOPA and gentler therapies that could be available. In a recent event at Nimans, Dr. Pramod and team spoke about the need for dietary and lifestyle changes to manage PD symptoms. Dr. Pratima, I'll come to you first. Have you made any such changes after your diagnosis? Could you elaborate on it, diet as well as lifestyle? You did talk about dance and meditation.
Yeah, I forgot to mention about something else as well. Support groups, they play a major role as well. I just completely skipped that bit. Now coming back to the diet and lifestyle, diet basically being a doctor, you're supposed to be healthy, you're more health conscious anyways. So you'll be take more on a vegetable fruit kind of diet anyways. But the thing with the medicine is you need to know how to take the medicine, how to time your medicine with your diet, and like protein diet and all those things. So that kind of helps, because my own time, the time of onset of levodopa, it all depends on when I take my meals, when I take my medication. So that kind of helps. It's kind of better utilization of your medication, taking it at the right time along with your diet. Okay. And again, there is this constipation thing, the non-motor symptom. The diet does help. It does help a lot with my constipation. The diet helps a lot with my constipation as well, which is one of the non-motor symptoms. Now, lifestyle-wise, I moved from a city to a much calmer place. I don't have to commute a lot. I don't live in a big city anymore. I live in a town. So that anxiety, the traffic. Now, if you live somebody in cities, you can say there's a lot of traffic. People are very mad. That's one of the major things. There's no commuting for me. There's no rushing over. I don't have a list of things to do. So those things, that's one of the major lifestyle change I made it. So I slowed down a bit. Now I'm not more like I had to make more research. I had to make a lot of money. I had to be marketing on myself all the time. So all that has taken a back seat. I enjoy nature now. I enjoy my walks. I enjoy my dancing. So my priorities have just changed, have shifted a little bit. That kind of helped me a lot. So these are the changes that, I mean, yoga is always there. Meditation helps me with my sleep. The yoga nidra is the best part. That always helps me with my sleep. There are a lot of things I need to cover. I'm just trying to say, jumping from one thing to the other. But when you say lifestyle, diet, and exercise, there's so many things to fit in. But I think I touched the basic ones.
You did.
Yeah.
Yes, Dr. Pratima, you did. And I think those suggestions, I think all of us will take to slow down, to take things slow, not rush into anything. That's, I think, one thing that I will take away from this session as well. Dr. Pramod, some of the side effects of medication can give the impression that the condition is worsening. What are these side effects that people should be aware of, and how can one manage them? If you could briefly tell us.
So I already told in my initial thing that we always explain about the side effects of the medications and what may happen. Now, there are peculiar thing in Parkinson's disease that some of the medicines has the initial side effects, then it goes away, but then they develop after about 5 years. In a general, I'm telling, after about 5 years of Parkinson's disease being treated with dopaminergic drugs like levodopa, etc., the patients start developing what is known as motor fluctuations, what is known as dyskinesias. Okay, so the patient was in the off state, means patient is having tremor and stiffness. The patients take the medicine. Earlier, the medicine is to give a good effect, and it is to last for about 4 or 5 hours. Then after over 2 or 3 years, it happens that what is wearing off occurs, the medicine effect goes away. But these are not a part of Parkinson's disease, because the cells are all damaged and getting less dopamine, etc. storage. But what happens is that in classical Parkinson's disease, the medicines itself, when the patient becomes on or patient has good improvement, they develop some type of overstimulation of some certain receptors, dopaminergic receptors in the brain, and they develop what is known as dyskinesia. So these dyskinesias are most often what is known as a jerky type of movement, a coriform movement, this type of dancing movements the patient develop after about 1 to 1.5 hours after the medications. And it is a very predictable way. It is called a peak dose dyskinesia. Okay. So these, when the patients develop, they feel that whether you're developing a new disease or something else is happening or the diagnosis is wrong, it is not correct actually. If the diagnosis is actually correct, the dyskinesias, most often the presence of a dyskinesia after about 3-4 years in Parkinson's disease is actually a thing. It shows that your some part of the brain is very healthy and it is overacted to the medication. So it is a way overstimulation by the dopaminergic drugs in certain receptors in the brain. So these are the things, but this is very disabling. It is not a very good thing. So they develop peak dose dyskinesia when they develop the improvement in the symptoms. As the medicine effect goes away, again, some of the patients can develop again some type of dyskinesia, stiffness, the dystonia, the bending of the legs. This is known as a end dose dyskinesia. Okay. So sometimes the patients can develop peak dose plus end dose. This is called biphasic dyskinesia. Even it happens in the later on in the disease after 10 years. So they develop much more these in the evening time and they just alternate between off and on and severe dyskinesias. So the dyskinesias is not a new thing in Parkinson's disease. It just shows that the disease has progressed and the side effect of the medicine is started taking place. So in this strategy will be to reduce the medicines and then go for deep brain stimulation, etc., which is not, I'm not discussing here. And there also there are changes are there which we can make. In certain drugs like ordinary levodopa can increase too much of dyskinesias. If you give dopamine agonist, the dyskinesia may be relatively less because the total strength of the medicine is less. Now, there is another thing is that non-motor symptoms again can be part of the drugs which initially did not produce. But it is not that the patients are all developing new things, but over time, over the horizon, again the non-motor symptoms emerge in a different way because some blame is there for the medicines. And one of the most important thing is the dryness. If some patients take medicines like anticholinergic drugs, they develop dryness of mouth, they develop bladder problems. But the most important thing what I want to highlight is that some patients they develop low blood pressure on standing. But it is not always that we go for another diagnosis, but sometimes many patients develop low blood pressure standing because of the medications, certain type of medications which need to be stopped. Then the another one is they develop swelling of the legs. They develop skin changes especially in the legs, certain drugs like dopamine agonist and amantadine. So they are the drug side effects of the drugs, but the patients are not developing any new thing. Finally, there are a lot of psychiatric problems the patients can develop. The disease itself can cause psychiatric problems. We know very well that the disease itself, different genetic disease can cause, but the drugs are one of the most important things which can precipitate it. Okay, like in the younger patients, if you give dopamine agonists, they can develop what is known as impulse control disorders. They can develop hypersexuality. They can develop, gambling tendencies, internet addiction. And this is more common in the young onset Parkinson's disease. These are just precipitated by the certain drugs. Finally, in the elderly people, more those who have developed some cognitive decline, some of the drugs can cause hallucinations. What is known as psychosis, they develop visual hallucinations. They see or hear something which is not there, mainly seeing something. So if the patient complains of this, immediately you have to stop most of the offending drugs and just maintain the patient on levodopa. So these are in nutshell all the side effects of the medicines which either causes or exacerbates some underlying problems in the Parkinson's disease over time.
Thank you, Dr. Pal, for explaining that in detail. We have one last question before we open the floor for questions. So this is a gentle reminder for all those who are participating to send in your questions in the Q&A section. Dr. Prashant, my question is to you. L-DOPA is the standard treatment modality and deep brain stimulation implant in severe cases. Are there gentler therapies to support the primary treatment? And for example, if you could give us a case, if you can recall a case where they have managed the symptoms with gentler therapies, diet and exercise. Dr. Pratima did touch upon that, but any specific case that you can recall?
Okay. I think when it comes to therapies, there are two aspects what I look into it. What patient is suffering from and how they are going to tolerate it. It's one's own problems, how they decide to tolerate about that. Okay. Sometimes people have subtle features They are very aggressive. They want treatment to be given full swing, and whatever you do it, they feel that it's not reaching their goals. Many times what we see is usually what we started is non-pharmacological management. Non-pharmacological management means we try to improve, we ask them to improve their lifestyle. Lifestyle means start having physical activities more, do regular exercises, stretching out exercises, group therapies. That's much more important because when it increases your social interactions. Improve your social interactions, being going to a temple, club, park. What happens when you start talking to people, when you start getting involved in things which makes you happier, your dopamine requirements becomes less. And what happens is, along with that, what you also see that you don't notice the problems associated with Parkinson's disease, and people tend to able to manage with that for a longer duration. I have seen some of what we call it as slow progressors. Slow progressors are a certain small subset of patients with Parkinson's disease where symptoms progress very slowly, and for some or other reasons, they have been able to manage without medications or with a very small dosage of medications for many months or years to go by also. I have some of the patients who have been not taken treatment for 5 to 10 years to go by. And there are other set of patients whom we see who are generally they want to avoid medications. It's their perception. They feel that taking more medication is much more harmful to them. And every person has their own right and their own interpretation of the situation. And we need to respect that. And when we respect that, that is where the goal of these alternative therapies, goal of physical therapies, all this starts making a critical role in the management. And their perception help us to go with what you call it as improvement in their quality of life. I will not try to tell it as a gentler therapy. I'll try to put it as a therapy which works for each person. A X person may be happier with a certain type of a therapy. A Y person may be happier in a different type of a therapy. Some people are more happy to get more tablets in their list and they see that, oh, I'm happy now. The doctor has given me more tablets and this means it will work. Some people are happy to have more costlier medications in their kitty, and with that they feel that yes, it's getting better for them. And some people, as you pointed out, they're happy just to avoid medications and to work. And yes, not only in medical what we give, there are alternative therapies, including Ayurveda and other things. Whatever medications do they give, that also contains dopaminergic therapies. Many people come and tell me sometimes that, oh, previously I used to take 2 tablets of levodopa. Now I've been taking 1 tablet only. How is that? I asked her. No. After I started X with Ayurvedic therapy, and then things have become better. It only means that I give them an example that it is eating a roti, 1 roti in each house, and feeling that still only 1 roti has fed you. It's basically you're still eaten 2 rotis or 3 rotis. That's how it goes on. But at the end of the day, their perception, their acceptance, what is there, that is most important, and that's how it works out. Thank you.
Right. No one formula works for all. It depends on what each one wants. Right. All right. We are right on time to close this discussion. So I'll just come to each one of you to quickly give me, one thing that you would want to tell the viewers of somebody who has been diagnosed with PD or a caregiver, the one thing that you would want to tell them and leave this discussion for them with. Dr. Pratima?
Well, being diagnosed
specifically with regards to stigma around Parkinson's. Yeah, please go ahead, Dr. Pratima.
Yeah, just being diagnosed with YOPD or Parkinson's the life isn't too bad as others portrayed or as you imagine. So take it as you go. It isn't as bad as you normally assume. So you can have a good quality of life as well. That's the only, with some input from your side, you have to work for it. It just doesn't come like that. So work for it, and it's not too bad. Life is not as bad as you imagine with PD. That's all.
Right, Dr. Pratima. Dr. Pal?
Yeah, I want to just emphasize to the patient and their caregivers that this disease is not at all, to be panicked for, and you will have a good life. But only thing is that you should confide in one doctor and regularly visit the doctor. There will be ups and downs. Do not panic, and everything will be fine over the next, at least for first 5 to 10 years, you should be able to do all the activities with minimal support, and be aware of some of the symptoms which people do not tell. There is non-motor symptoms like depression, anxiety, hallucinations, etc. If you have these problems, you should tell your doctor, and there are medicines are there to treat them.
Right. Thanks, Dr. Paul. Dr. Prashant, your closing remarks.
I'll tell them enjoy life to the fullest, and God has given you a disease where treatment is also been provided, and we are there to help you out. Go out and enjoy yourself.
Thank you so much, panelists. To sum up that discussion, I think breaking the stigma around Parkinson's first involves understanding Parkinson's disease, the signs and symptoms associated with it, understanding it, recognizing it, and accommodating it from an individual perspective as well as from the perspective of the society. Thank you so much, panelists, for that insightful discussion. Thank you, Dr. Pratima, Dr. Pramod Pal, and Dr. Prashant.